I'm Michael Davies. I'm a professor in reproductive epidemiology within the Robinson Research Institute at the University of Adelaide. As an epidemiologist, I'm concerned with the distribution and causes of disease at a population level. One of the most straightforward things they can do is to stop smoking for the duration of treatment and pregnancy, at least, and longer if possible, because that will effectively double their chance of having a successful treatment cycle and therefore minimise exposure to all of the invasive therapies. Managing weight is also very effective at increasing the chance of treatment while also reducing the risk of adverse events in pregnancy. The health and welfare of both the mother and the baby have been of intense interest to us for some years now, and we've published fairly comprehensively on this. And again, there are both contributions from the mother, potentially, and maybe perhaps even the father, in addition to certain treatment factors. What we do know is that the babies born from assisted conception are comprehensively disadvantaged with regards to routinely reported perinatal outcomes. There's an increased risk of major birth defects, increased rates of low birth weight, very low birth weight, preterm birth and very preterm birth, stillbirth and neonatal death. And we have perhaps uniquely also observed there's increased risks of cerebral palsy, due both to the treatments perhaps, but then also to the multiple pregnancy rates. This is commonly cited that the great majority of babies born from IVF are normal or relatively healthy. However, what we see at a population level is that this contributes an enormous burden of disability, death and disease. The high risk of multiple births in IVF is due to transferring several embryos at once. And this was introduced in the early 80s to overcome extremely low pregnancy rates. And what's happened since is that implantation rates have improved dramatically due to increased performance in the laboratory. And we now have an epidemic of multiple births around the world, where in some clinics the majority of babies born are born from multiple gestations. In order to reduce this epidemic, we in Adelaide, for example, introduced a single embryo transfer trial to try and reduce, if not eliminate, the excess of multiple births. So that having a single birth is healthier, certainly healthier for the baby, and dramatically reduces the risk of complications in pregnancy for the mother. It's a case that single embryo transfer is actually seldom used in IVF clinics, and it's highly variably used. In some countries, in Sweden, for example, it's been legislated that single embryo transfer should be the norm. In Australia, single embryo transfer is the norm, but that's through a voluntary self-regulation process. It's 95% of all treatment cycles, for example, in South Australia. However, in the US, it's still the case that over 20% of all births are born from multiple gestations, and that because of the expansion of the technology in the market, the total number of twins in the US and higher order pregnancies continues to grow. Well, one can start to try to, for example, change the hyperstimulation protocol to tailor that more specifically to the metabolism of a woman. One can also use frozen cycles rather than fresh cycles, so that to allow the endometrium to recover somewhat more for the preparation of implantation. One can choose less invasive procedures. For example, it's now the case that ICSI, which is really very invasive, is now the predominant treatment globally. However, what we know from a very large study in the US is that it may produce higher fertilisation rates, but the take-home baby rates are no better than traditional IVF, but the perinatal outcomes are worse. The question of whether IVF is getting safer is a very important one. We've recently been funded to investigate exactly this question by having a cohort study of the entire population of South Australia, where we can look across the entire history of IVF treatments and see how procedures have changed, and then look at perinatal outcomes. Internationally, what's become apparent is that some of the adverse perinatal outcomes are starting to improve, even amongst the singletons. Some of that may be due to increasing use of single embryo transfer. However, one suspects that there's been improvements in the embryology as well. Culture medias have improved, but then also the use of high-quality incubators is now more widespread. What we see are higher birth rates that are due perhaps to better embryology and higher quality embryos being produced. It's important to consider that IVF can also be used to reduce the risk of certain types of defect in children. It can be used for screening for genetic abnormalities, for example, that may be familial and concentrated in certain populations. And so we can actually screen embryos and choose an embryo that is missing perhaps a defective gene. And in the future, it may also be able to be used for screening, whole of population screening to reduce the risk, for example, of cystic fibrosis.